So today we have adequate evidence to say that balanced fluids are preferred in most clinical circumstances in critical care medicine for resuscitation purposes. Now we have 4 balanced salt solutions available commercially, and they significantly differ amongst themselves. We have Ringer's lactate, which is probably the most widely used balanced fluid. We have Plasma-Lyte and its various other salt solutions named by different commercial products, and like Kebilite and etc., etc., etc. And we have Stirofundin from B. Braun. And finally, we have Ringer's acetate. However, the Ringer's acetate is not available in India. Now, how do we choose between these balanced salt solutions? Which one to use for our patient? Now, to decide about this, we have to consider 4 factors. First of all, we need to consider what is the SID or the strong ion difference of the crystalloid. For example, Ringer lactate has a strong ion difference of 27, Plasma-Lyte has 50, and Stirofundin has 27.5. The eventual effect of balanced fluid resuscitation on the pH or acid-base balance of the patient will depend upon the SID of the crystalloid and the baseline plasma bicarbonate of the patient. If the crystalloid SID is more than the plasma bicarbonate of the patient, it will always produce alkalinization after large volume of the fluid. In contrast, if the plasma bicarbonate at the baseline of the patient is more than the SID of the balanced fluid or the SID of the crystalloid, it will produce acidification. That's the reason you get hyperchloremic metabolic acidosis with 0.9% saline, which has an SID of 0. Mostly balanced fluid solutions, because they have the SID of more than the normal bicarbonate value of 24, they usually produce alkalinization. However, in certain clinical circumstances where there is a baseline chronic metabolic alkalosis, infusion of resuscitation fluid, a particular resuscitation fluid, may produce acidosis or alkalosis based on the SID. Second factor to consider, and this is very, very important, it is to consider is the crystalloid's effective osmolality. Because we know the lower the effective osmolality of the crystalloid compared to the serum or the plasma, this will have a tendency to increase the brain swelling in a patient of traumatic brain injury or any patient who has got a propensity to have higher intracranial pressure. And we need to consider that Ringer lactate and Plasma-Lyte with an effective osmolality of 254 and 270 has osmolality less than the plasma osmolality. Whereas Stirofundin has got an osmolality of 290. So in patients with traumatic brain injury, Ringer lactate should not be used at all. And in patients with traumatic brain injury, Plasma-Lyte should be used only with extreme caution. We also need to consider, thirdly, the metabolism of the buffer base. Compared to Plasma-Lyte and Stirofundin, Ringer lactate has got a buffer base of lactate, which is metabolized in the liver. And in patients with severe, extensive chronic liver disease, there is a potential for harm associated with hyperlactatemia when we use large volume of Ringer lactate. But this needs to be proved in clinical studies. In contrast, acetate, which is present in Stirofundin and the Plasma-Lyte, is metabolized in all tissues, and they are relatively safe in all clinical circumstances. There is a theoretical concern, fourthly, to consider calcium content of certain balanced salt solutions like Ringer's lactate and serofundin, and its potential for interaction with citrate in stored blood. But the clinical relevance of the same needs to be proven in subsequent studies. And fifthly, let us not forget the cost. The cost of newer balanced crystalloid solutions like Plasma-Lyte or Stirofundin is exorbitantly higher compared to Ringer's lactate. So based on these 5 factors, we need to choose a particular balanced fluid in our patients.